Hello everyone, I'm Kim Bischoff, the Executive Director for the NF Network, and we would like to welcome you to our webinar series. Tonight, the NF Network is pleased to present Dr. William Slattery of the House Ear Institute. The focus will be on advancements in auditory brain implants, or ABIs, and cochlear implants, CI. It's captioned. You should be able to see the captioning on your screen. The House Ear Institute is a world leader in ABI experience and success. There's many people who have benefited from the sound sensations received from ABI. The CI is even better for those who have cochlear nerve function. Tonight we have 82 people registered to participate. We'd also like to thank Marsha with Captions Unlimited for providing the captioning this evening. I have a few instructions before we get started. After Dr. Slattery's presentation, there's going to be two different ways that you can ask the question. If you look at your box to the right, you'll see there's a little question box, and you can type a question in there, and as time allows, I will read those questions for Dr. Slattery to answer. If you have called in on the conference call, your phone is muted. There's a box there, a little hand. If you click on that, I can unmute your phone and you can ask the question verbally. And if you find that webinar control panel is in your way, there's an orange arrow up there. You can click on that and it'll push it off to the side so that you can see it a little bit better. We did have a few emails earlier today. Some of the people on the East Coast were having a hard time dialing in. This will be available online within a couple of days at the nfnetwork.org website. So now I'd like to introduce to you Dr. William Slattery. Thank you for joining us tonight.
Well, thank you for that very kind introduction. I really appreciate everyone's attention, and hopefully we'll get everybody's questions answered as we move forward through tonight. So I'm going to talk about advancements in cochlear implants and the ABI. I thought before we did that, it would be good to talk about the anatomy of the normal ear. So normally, sound comes through the ear canal. Let's look at this little video of how sound works. We have sound waves coming into the ear canal. That vibrates in the eardrum. And sends a sound wave into the ear or the cochlea, where it actually stimulates the hearing nerve. Now it's the hearing nerve where all these tumors usually start, more specifically on the vestibular portion of the hearing nerve. Now a cochlear implant was developed for individuals who lost hearing from the inner ear. The most common type of hearing loss is either people who were born with hearing loss, children born with hearing loss, or problems with other types of hearing loss, such as infection, diseases of the inner ear. These were the most common causes of hearing loss for which the cochlear implant was developed. It was initially developed at the House Ear Institute in the 1960s, and throughout the 1970s and 80s it was commercialized. There are currently three companies making cochlear implants in the United States. So the cochlear implant works a little bit differently than the traditional hearing aid. So we have a microphone that picks up sound and sends it to a speech processor through a thin cable. The speech processor is powered by a battery, which you can think of it as a computer that converts the sound signal into electrical code. Now when we talk about a cochlear implant, recognize that the auditory brainstem implant works very similar. This processor takes the signal and sends it to the antenna transmitter. That sends the signal to a part that's situated underneath the skin, which is our receiver stimulator. That sends it to the electrode array. Now, the electrode is actually embedded in the inner ear in a cochlear implant. With the brainstem implant, the electrode array is actually on the brainstem and stimulates the area called the cochlear nucleus. The cochlear nucleus is the anatomical portion of the brainstem that is responsible for processing sound. Normally, the sound waves come into the hearing nerve, which goes into the cochlear nucleus, or that part of the brainstem.
Dr. Slattery, excuse me just a minute. Everybody's having a really hard time hearing you. There's a bad echo going on. I apologize for interrupting you. Is there any way that you could, maybe there's a interference with your computer laptop and with the phone together? Yeah, do you know how to, can you turn your computer mic off?
Yeah, my computer mic is on silence. But I was also hearing the same type of echo.
The only other thought I can think of is, Marcia, I know you're on too. Why don't you come off the phone? I wonder if it's being generated on your end.
Let me know if that's better. Kim, are you still on? Marcia still on the phone?
Yeah, I'm hearing an echo still. Marcia, are you off now? Are you off the phone? Do we still have an echo going on?
How about now?
Nope, I'm still getting an echo. Still getting an echo.
You still have an echo?
The only other thing I can think of is to have you dial back in, Dr. Slattery. Maybe it's just a bad phone line.
How about now? Is that any better?
Try again.
Can you hear me? Testing 1, 2, 3. Can you hear me?
Yes, now I can hear you fine.
Is there still an echo?
There is, but it's on my end now, I think.
Okay, because I do not hear an echo now. I'm actually hooked up to my computer.
Okay. Somebody just said better online. I've got the echo now, but I'm not the one talking, so we'll be okay if it's on my end. I'll just be quiet, and I'll turn it back over to you, Dr. Slattery. Go ahead.
Okay, sorry for that. If anyone hears an echo, please let me know, and we'll try to fix that. So we're talking about how a cochlear implant works. So the cochlear implant here is one of the older implants, and I think this is important because it has a body-worn processor, which is similar to some of the old ABI material. So we have the sound processor that picks up the sound with the microphone. That picks up the ambient sound around us. It transmits it down the cable into the speech processor. Now the current speech processors are all worn as a behind-the-ear type of device, but I think again this illustrates the picture a little bit better. So the sound processor, as I mentioned, has a computer, has a battery, processes the sound and decides how that sound is going to be stimulated into the inner ear. From there it goes up to the transmitter, which sends the signal across the skin. In a normal cochlear implant there are two magnets. One magnet that's located inside on the receiver and the second that is located on the outside antenna. And the purpose is the two magnets will line up the antennas so they can transmit sound efficiently. As you're probably aware, with NF2 you need MRI scans, and for that reason we cannot implant a magnet in patients with NF2. So we actually will take the magnet out, and then there's a little sticky magnet that's worn on the skin. That will transmit sound into the inner ear or into the receiver, and then that will transmit down the electrode. In the case of a cochlear implant, it goes into the inner ear, stimulating the cochlear nerve, and in the case of an ABI, will actually stimulate the brainstem. Now I think it's important to understand who are cochlear implant candidates, And just in general, I want to talk about candidacy. So children are probably about half of the patients who receive cochlear implants are actually children. And we'll implant a child as young as 12 months of age. Sometimes we'll even go down younger than that when we're confident that the child definitely has hearing loss. The children, when they're implanted, take a little bit of time because, of course, they have to learn how to understand this electrical stimulation, which is definitely foreign to them. Fortunately, most of the children are picked up with neonatal screening, and so we know they have very poor hearing at birth, and then we'll actually put them through a series of hearing aids, and if they receive no benefit from that, then they will receive the cochlear implant, usually somewhere between 9 and 14 months of age. These children actually do remarkable when you see them several years later. They've developed good speech and language skills. They still have hearing impairment but do very well with the cochlear implant. As far as adults are concerned, the adults receive a cochlear implant where they no longer receive benefit from hearing aids. And so that's usually patients who have a hearing loss that's greater than 70 decibels in the better hearing ear, and they have sentence scores that are less than 40% or word scores that are less than 30%. And again, I think it's helpful with this to understand what the normal guidelines are for cochlear implants, because when we put a cochlear implant in a patient with NF2, it's actually outside of the FDA guidelines, because the FDA guidelines actually state that a cochlear implant can only be used in patients who do not have tumors on their cochlear nerves, which of course are the acoustic neuromas or vestibular schwannomas, which all NF2 patients have. But what we found is that most of the time we can receive coverage for this, even though the FDA may say that's outside of normal boundaries. Now, of course, with NF2, just to kind of review, everyone in this phone call is here because of NF2. And the definition of NF2, of course, is usually people who have bilateral acoustic neuromas. There are rare cases that we do see what's called mosaicism, where patients can have a first-degree relative with NF2 and some of these other tumors that are listed in this slide. Neurofibromatosis, as most of you are probably aware, about 50% of patients have no family history. 50% of patients do have a family history. The average age of diagnosis is about 22, and the incidence is about 1 in 40,000 live births. Now, one of the problems when we talk about outcomes of cochlear implants, we talk about outcomes of auditory brainstem implants, is that there's so much variability in acoustic neuromas that we know that, for instance, sometimes we see very small tumors that you see up here on the right-hand side, to medium-sized tumors, to very large tumors. And the problem that happens is if you look at the brainstem, you can see the brainstem in this small tumor is very good. The brainstem in the moderate-sized tumors gets compressed, and then the brainstem in the very large tumor is very much compressed. And that can be a problem, especially if we are trying to put an ABI or brainstem implant and trying to locate where the hearing portion or the cochlear nucleus is in these tumors. So there is some variability that we see. The other thing we see is that the mutations sometimes are associated with what we call the phenotype, meaning that there are certain mutations that have much more severe disease, and then there are other types of mutations that have very mild disease, and then there's some mutations that we just have no idea what, or are unable to predict what's going to happen. And the only way you can know what your mutation is or the genetic abnormality is to actually have a test done. And in the milder form of NF2, it can be very difficult sometimes to determine what the specific abnormality is based on how the tumor is tested. Now, let's move forward and talk about auditory brainstem implants. And I gave you the other information mainly as a backdrop, so hopefully it would help put us all on the same page. So as we talk about auditory brainstem implants, everybody's coming from the same place. Now, I can't talk about auditory brainstem implants without talking about Marilyn Davidson. Some of you in the NF2 community know Marilyn. And this is a picture of me in my younger days with Marilyn. Marilyn was the first ABI patient, and she was implanted in 1979. And Marilyn is my hero because I think without Marilyn, there would not be an ABI program. And she is just such a brave individual. She's still using her ABI today and is just a wonderful individual. I asked her one time, I said, Marilyn, I said, you know, you were very brave. They were going to hook up an electrode to your brain. Nobody knew what the results would be. They weren't sure if this was going to shock your brain or overstimulate your brain. Just nobody really knew what would happen. And she said, well, I understood those risks, but, you know, I had a family history of NF2, and I thought, you know, somebody needs to be the first one to take the risk. And because her mother had died of NF2, she was willing to take that risk. And I tell you, I just think she's just such a wonderful lady for allowing this program to get started. And so Bill House and Bill Hitzelberger were the first ones to do the ABI in 1979, and Marilyn was the first recipient of the ABI. And I just think, again, I think so much of her. She's just a wonderful lady, and I just love seeing her. So from 1979, the device has improved. This is a picture of one of the older box devices, the Cochlear device, to kind of show how it's done. This part of the speech processor is no longer needed for most of the devices. A lot of patients can now wear the ear level processor just behind the ear. So we have behind the ear the speech processor, the microphone, and the battery that picks up the sound and sends it to the coil, which transmits it to the internal device, and that sends it down into the brainstem. And this is what the current electrode stimulation pad looks like for the brainstem implant. So this is a picture of the internal device. This is what's actually implanted under the skin. So you can see here is the antenna receiver. There's an area of a removable magnet. There is some computer circuitry inside the internal part, which basically protects against any sort of excessive shock. And then the electrode comes down to this little electrode pad where there's 21 electrodes. This is then a ground electrode that's placed under the muscles. So this picture here gives us a history of the auditory brainstem implant. You can see the initial was a small electrode ball, 2 ball electrodes, and this went into a pad, a 3-pad, and an 8-pad type of device, and then that moved forward into the current 21 electrode device that's used today. This is on a Telfa pad that helps hold it up against the brainstem, but these are the electrical current areas that actually transmit the signal. And what we can do is we can transmit the signal across narrow electrodes or across broad areas of electrodes, and this increases the amount of stimulation that can occur with the electrical pulse that goes in, and depending on how the electrode sits on the brainstem will determine how much electrical stimulation we need to provide. So here again is a picture of the ABI. So it is underneath the skin. We bypass the inner ear, bypass the hearing nerve. We have the surface electrode that goes in, and in this case this is also showing the penetrating electrode, which I'll show in just a minute. So the criteria for the ABI is patients who have NF2 in 12 years of age or older. There is no audiometric criteria, meaning that patients with whatever kind of hearing you may have when the tumor is removed, the thought is that you're going to lose the hearing. It can be done when your first tumor is removed or your second tumor is removed. Now, we do know that gamma knife therapy can be a problem. Some patients don't do quite as well with the gamma knife and the ABI, although we have some patients who still do very, very well, and I'll talk about that in just a few minutes. Our experience, we're actually over 250 ABIs right now. This is an older slide. Most of the patients have the multi-channel ABI. We do have some teenagers that have the ABI. There have recently been some children implanted, mainly in Europe, that do not have NF2. That's a completely different story, where there's ABIs being used for children who are born deaf, and when their ear developed, it did not develop properly, so they can't have a cochlear implant, so they actually have an ABI. Now, this is a group of scores. The higher the number, the better the score, and what this shows is that patients who have an auditory brainstem implant do quite well with both vision and sound. And of course, this is what many patients with NF2, you're very good lip readers, probably because you lost the hearing slowly over time. Many of our NF2 patients are very good lip readers, and this does tend to enhance the lip reading ability. Now, this slide, what it shows is that over time we see continued improvement with the ABI. So early on, patients don't do quite as well, but with time, even up to 8 years, you can see that there is a trend in this slide going up and getting better and better and better, that as patients use the ABI more, they tend to do much better with the ABI. Now, one of the concerns we had is trying to see, can we make the ABI better? And so what was a collaborative project between the House Ear Institute, Huntington Medical Research Group, and Cochlear Corporation, and the NIH funded this, National Institutes of Health. We actually worked on what's called a penetrating ABI. And in this case, you can see here's the electrode pad, here is the penetrating electrodes. The idea is that the brainstem is organized in such a way that rather than just stimulating the surface, if we had little electrodes that went deeper down into the brainstem, that we might be able to get better stimulation. Now, I want to make sure you see, this is a reference here. This is 2.5 millimeters, so these are not really long. This is 4 millimeters, which is about, if you think of 4 millimeters, it's about the width of a pencil lead of your pencil. So it's very tiny. So this slide is very, very blown up. But the idea is that we know that the cochlear nucleus, or the part of the brainstem that's responsible for sound, is organized in different ways, meaning that if you think about the inner ear is set up as a like a large, I call it a large piano, where you have keys. You have low frequency sounds and high frequency sounds. And so the inner ear is kind of set up in what we call a tonotopic organization, meaning that one part of the ear hears low tones, another part of the ear hears high tones. Well, we also know that the brainstem is organized in a similar way. So the thought was maybe we could get better stimulation by using this penetrating ABI. And so here we knew that low frequencies were closer to the surface of the brainstem, and higher frequencies were associated with deeper areas of the cochlear nucleus or the brainstem. And so that was the thought process with the penetrating ABI. And so the idea would be is we'd have the surface ABI and the penetrating ABI, and the two of those would actually work together. And so as part of a project, we had this little tool that would hold it in place and then allow us to put the penetrating ABI into the cochlear nucleus. Of course, we have to do this very, very carefully to make sure that we don't injure any vital structures of the inner ear, or I mean of the brainstem. And so in doing that, we had a special tool that was developed to do this. Now what we found is there's been 10 patients implanted, and some of the patients do very well. The second patient was a star patient, did great, had what we call pitch perception, meaning they could hear low tones, they could hear high tones with their ABI, but then the other patients just didn't get quite as good of results. And as a result of that, even though we did 10 of these, we said, you know what, we still don't understand this enough. We need to do a little bit more work. So we're currently working to kind of redesign the penetrating electrode. But right now we found that with the surface electrode, there's some techniques that can be done to actually improve the outcome of the surface device. So overall, what we find is that the ABIs worked very well for patients, especially when there's been no other alternative. The penetrating electrode, we hope that in the future may give us some better performance, but we do know that there's some techniques that can be done to actually help, and we're finding that that is something that we're able to do and get better results with the ABI. Now, that's the ABI discussion. I'd like to now move forward then with the cochlear discussion and talk a little bit about the cochlear implant. And so this shows you kind of a picture of the most recent cochlear implant. Here is the cochlear implant, which is again similar to the ABI with the exception of the electrode pad. And then the behind the ear speech processor, it has the antenna all in one compartment. And there's a little remote control that can charge this and control some of the sound quality. So when we talk about ABI performance, one of the things we have to look at is we know that some patients with cochlear implants do much better. We know, as an example, the younger the person is, as far as an implant, a cochlear implant is concerned, do much better. Patients with cochlear implants that have higher IQs do much better. Patients who have excellent lip reading ability do much better with cochlear implants. With NF2, as I mentioned before, there is so much variability that it's there's still a question of who is a potential cochlear implant subject. And so we recently looked at this, a group from our institution, and you can see here we have a cochlear implant on one side and a brainstem implant on the other side, and we compared some of these patients. So what we do know is that the ABI in some patients just do fantastic, have open set understanding, meaning we've got some patients who can talk on the telephone, but not all patients are there yet. And that's one of our frustrations, and of course frustrations of the community, of the NF2 community, is that we have patients who still have difficulty and don't do as well as we would like for them to do. So here's an example of a patient. This patient had an acoustic on one side and a cochlear tumor on the other side, but had very, very poor hearing. So the implant was actually placed into the inner ear on one side, and the patient had the tumor out on the other side and had an ABI placed on this side. Now, we have 10 patients, as I mentioned, NF2 patients who had ABIs and had a cochlear implant on the other side. And so we actually compared this group of patients to say, you know, which is better? Is one better than the other? In the cochlear implant group, 2 patients had had previous gamma knife. 4 patients had had resections prior to their cochlear implant, and then all of the patients still had an acoustic aroma on the side of the cochlear implant. So typically the patient that's going to receive a cochlear implant with NF2 is a patient that has a tumor on one side, but their hearing has gotten to a point where they no longer can use a hearing aid or receive any benefit from any type of normal acoustic stimulation. Some of these patients have received radiation therapy, and of course we're seeing more and more patients who now have tumors that are stable tumors. The tumor's not growing, but they've lost their hearing as a result of radiation therapy or gamma knife. And in those select patients, some of them are candidates for a cochlear implant. Now we can do what's called promontory stimulation. So promontory stimulation is a test where we can actually, in the office, test the hearing nerve to see if somebody can understand low tones versus high tones. If in doing this test in the office you can perceive low tones and high tones in the ear that's deaf, then that would be an ear that we'd consider putting a cochlear implant in. So when we looked at our patients with cochlear implants and ABIs, out of these 10 patients, 2 of the patients did not receive any benefit from their cochlear implant. Now, unfortunately, 1 patient in this group did not receive any benefit from their brainstem implant either. And as I said, one of the things we do know is when we have big tumors, the brainstem gets distorted and it's more difficult to receive benefit. What we can see, though, is that in the patients that had cochlear implants, they tended to do a little bit better on some of the different scores.
If you look, however, on these sentence scores with lip reading, they all do exactly the same. Now with sound only, the cochlear implants do a little bit better, but you can actually see with lip reading, we get a very similar between the auditory brainstem implant and the cochlear implant. When we look at sound plus lip reading and everything together, what you'll see is that we still see with the ABIs, the cochlear implant was a little bit better than the ABIs, although both groups did very similar. And this was actually not statistically significant in that test. One of the things that we noticed is that there were problems with declining performance in 4 of our cochlear implant patients. One of those occurred 11 years after Gamma Knife. 3 of the patients had growing tumors. And the tumor size was anywhere from 2.65, or actually ranged from 1.6 to 5 centimeters in size. And what we saw is over time, these tumors would actually grow, and that's probably why the patient lost their ability to receive benefit from the cochlear implants. In the patients who were our top cochlear implant performers, what we saw is that their duration of deafness tended to be about 6 years, meaning that the longer you go, the less likelihood you may have as far as receiving benefit from a cochlear implant, and the average tumor size was much smaller, about 1.6 centimeters. So I think if we have patients who have had Gamma Knife, those are the patients with smaller tumors that we would consider for a cochlear implant, patients that the tumor's not growing. Now, one of the issues that we find is, as I mentioned earlier, is most patients with an ABI continue to improve over time, and the problem, of course, is that with time, the cochlear implant patient may actually end up doing worse, either as a result of radiation therapy or a result of the tumor growth. Now, there is a difference as far as treatment. The ABI placement, patients are only in the hospital for a couple of days, whereas with the cochlear implant, it's usually done as an outpatient. So there are some differences there. So the cochlear implant, we believe, is a reasonable alternative to the ABI. When the hearing nerve is present, there tends to be better results in those individuals. But of course, we have to consider the tumor first. If the tumor is actually growing or there's a big tumor, doing a cochlear implant is not going to be a good idea in that situation. So if it's a smaller tumor that's not growing and the hearing's been lost, that would be a case to consider a cochlear implant in that situation. So the important thing here is that I think we have now at least 2 different alternatives, the auditory brainstem implant and the cochlear implant, as an option for patients who lose their hearing or have large tumors that are going to lose their hearing. So I hope that's been helpful overview of the advances in the auditory brainstem implant and the cochlear implant. And I'll stop at this point and see if people have any questions or topics for discussion.
Well, thanks, Dr. Slattery. That was really helpful for me. There are some questions here. I'm going to read them, but I know that there's an on my side. The first one is, my daughter has a 3.3 centimeter meningioma in the posterior occipital region. She's asymptomatic. What size do you recommend removal?
Well, you know, that depends on a couple of things. A 3.3 centimeter tumor is a fairly large tumor. If it's in the occipital area, that's an area that tumors can get quite large before they cause a problem. So I think that's one of the things we'd have to say. In number one, is it growing? Is it affecting any of the nerve function? Is it affecting her brain function? I mean, I always offer patients, if ever you want to send a copy of your X-rays, I'd be happy to take a look at them and give you some treatment options. But I think it really depends on the situation with the 3.3 centimeter tumor.
Okay, thank you. So let's go to this one here. What are your feelings about Promontory stimulus tests for determining ability to have success with a CI?
Yeah, so that's the Promontory stimulation test. I think it can be very helpful. What it's helpful for is if it's positive, meaning that if a patient can discern low tones and high tones, then it's very helpful for us predicting that that patient will do better with a cochlear implant. On the other hand, if the Promontory stimulation test is negative, meaning the patient receives no benefit or cannot discern low tones versus high tones, if the situation were right, I would probably still consider a cochlear implant because there have been cases where the test is not helpful or the test is negative and the patient still does well.
All right, thank you. Here's another one. If someone has VS regrowth following a translab VS resection and ABI transplant, can that VS be radiated, and does it affect the ABI? Or if it is resected again, is the ABI affected?
So if the patient has regrowth of a tumor following a translabyrinthine approach, going back in when the ABI has been placed can be very difficult. The ABI can be affected. It depends on the location of the tumor, but you have to be very, very careful that you do not displace the ABI. Radiation therapy can be done and has been done on patients who have an ABI, although it's something that we try to avoid if at all possible.
Okay. My ABI was placed in 2007 at house. From the start, it has not functioned. No auditory sensation. What are some reasons for non-function?
Well, we believe the most common reason for non-function is that the device may have moved. When we put the ABI in during the initial surgery, the ABI is actually tested in the operating room to make sure that we have good placement of the ABI. And we do quite a bit of testing in the operating room to make sure that we know exactly where the ABI is located. Unfortunately, if someone has a very big tumor or the brainstem is very pushed out because of a big tumor, there can be the possibility of the ABI moving during the initial healing process, and we believe that's why patients do not receive any auditory reception. There have been cases that also, one of the things that we also know that in some cases the brainstem is actually involved with the tumor, and the cochlear nucleus, or the part of the brainstem that's responsible for hearing, has actually been destroyed as the tumor has grown, and that's another reason why some patients do not do as well.
The question on the same topic. I have an ABI, and it was put in 1994 as part of an FDA study, and it doesn't work. It was thought to have moved out of place. Have you replaced old implants with newer ones?
We have gone in and replaced old implants with newer ones. The results from that have not been as successful as we would like. Some patients have done well. If you had yours placed in 1994, you probably had one of the first multi-channel implants, which was one of the first cochlear devices. There have been some changes in the implant done since that time. We usually will do a CAT scan to actually look at the location of the implant to see if the implant's in the right position. There's a special technique that can be done with the CAT scan to actually look at
the implant. Also, an MRI scan can also sometimes help determine exactly where the implant is located. So I would say the first thing I would consider doing would be to get an imaging study to look at your implant to see what the problem is.
Okay, thank you. Another question. If there is a real risk of movement after a large tumor removal, does it ever make sense to do the implantation a few months after tumor removal?
Well, that's a very good question. If the tumor was very, very large, you could do surgery at a second time, but that would mean a second brain operation, which, as most of you with NF2 know, you'd rather not do. If we can get good electrical stimulation at the time of surgery, what we found is there's some better ways to actually hold the implant in place, and we found better success with that now. There have been rare cases where we've actually done just as you've suggested, that is, get the tumor out and then come back later and put the ABI in.
Thank you. After an ABI implantation, how well can one see around the brainstem area? Does it block a lot of the brain area so that the doctors cannot see if there may be regrowth?
No, there's no problem seeing regrowth after an ABI. The ABI at the brainstem usually does not cause any problems with changes in the MRI scan. The electrical component that sits under the skin that I talked about, where the antenna is, that part does cause a little bit of distortion on the MRI scan. There are some ways to do an MRI scan to prevent that distortion and make sure that it's not a significant problem. So in general, it's very rare that that's ever a problem.
Thank you. Then another question is it possible to get an ABI if you have a number of tumors, meningiomas, compressing the brainstem, in addition to 2 vestibular schwannomas? Would the ABI be in the way of future surgeries that might be needed to remove regrowing tumors in this area of the brain?
One of the things we try to do when we put an ABI in is to make sure all of the tumors are taken care of either in the area where the ABI is going to be placed or where there may be future surgery that's going to be performed. We try to make sure those can be taken care of at the same time. Rarely there are times where that cannot be done, and so we go ahead and put the ABI in. As long as the surgeon is skilled with the ABI, we have not found that to be a problem with treating other tumors if they grow later in time.
Okay, thank you. With the brain stem under pressure for some years and total deafness for some years, does it still make sense to insert an ABI?
I think that depends on the individual's living circumstances. If you've been comfortable with deafness for 10 or 20 years, you may be very comfortable in that situation. On the other hand, if you do want to try to hear, I think trying to take the tumors out and put a brainstem implant in at the same time is a very reasonable thing, if for nothing else to help with lip reading skills and from a safety perspective to alert you to environmental sounds.
Okay, and then here's one that's a little bit different. Oh, there's 2 of them here. What do you think of the BAHA use for NF2 patients? Are you able to have this with multiple MRIs? I'm not sure what that is.
Yeah, so the BAHA, B-A-H-A, all in capitals, stands for Bone Anchored Hearing Device. The BAHA is useful for patients who have a single-sided deafness. Single-sided deafness, basically the BAHA takes sound from the deaf side and sends it to the good hearing ear. We tried BAHAs in several patients, or at least used stimulations similar to the BAHA in several patients with NF2 who were completely deaf, and they did not receive any benefit from them. So I don't think BAHA is a good option for patients with NF2.
Okay, very good. Thank you. Next question is, would you address photodynamic therapy as part of the NF2 treatment protocol?
Photodynamic therapy, someone's going to have to tell me what they mean by photodynamic therapy.
All right, Linda, if you would type in an additional section to that question, I'll read it then once it comes up. That was Linda Woodard. And then we'll move on to this one while we're waiting. If Promontory test is negative for stimulation, does that necessarily mean that a CI is not possible?
If the promontory stimulation is negative, it does not mean the CI is not possible. It means that you may not do quite as well with the CI.
And then this question's from Ben. He says, what are the options available when having cochlear implant or ABI and then needing an MRI scan?
There's no problem with a cochlear implant or an ABI and having an MRI scan as long as the magnet that was placed in the device is removed.
Okay, well, now I'm going to switch to someone who would like to ask a question by phone. So this is for you, Jamie. I'm going to unmute your phone, Jamie. So why don't you go ahead and ask your question. Are you there, Jamie? Jamie, can you hear us? Well, we can try again, Jamie, a little bit later. Here's another one. This is Laura Didier. Laura, I've just unmuted your phone. Are you there, Laura? You know Laura's been asking her questions by writing, so maybe that was a mistake. All right, let's see. Let me go back to the questions up here then. All right, let's go to this one here. When would you recommend a translab approach over retrosigmoid approach for VS removal?
So in general, the translabyrinthine approach does not retract the brain, whereas the retrosigmoid approach, you have to retract part of the brain or the cerebellum to get to the vestibular schwannoma or acoustic neuroma. The translabyrinthine approach is very good when the patient has already lost hearing, or we have a large tumor in which the chance of saving hearing is so poor that we know there's going to be loss of hearing. Most of the time, most centers would agree that a tumor larger than 2 centimeters in size, it's very difficult to save the hearing when the tumor gets to be that big. And so for that reason, it's usually if there's no hearing in the ear, or if the tumor is larger than 2 centimeters in size, we'll generally consider a translabyrinthine approach in most patients.
Okay. Frederick has a follow-up question here. He says, again about the brainstem pressure. When tumors are very large, is that a contradiction for an ABI?
No. We've put ABIs in patients with 5 and 6 centimeter tumors. It's just we like to do it when the tumor is smaller because the anatomy is much better and allows better placement of the device.
All right, and this one here is from Marie. Have statistical benefits of the ABI improved or changed much over the last 10 years?
The results of the ABI have gotten much better. The number of patients who do well has improved over the last couple of years. The most likely reason for that is because of improvement in intraoperative testing and surgical technique, which has resulted in better outcomes.
All right, and this one here is from Jessica. If my son was to get an ABI, how would the MRI team know what to look for tumors, ABI? What to look for tumors, ABI?
Well, the MRI team, we give patients a card so the MRI team know what to do with the ABI and MRI scans. Does that answer the question?
I hope so, and if it doesn't, please go ahead and type in a follow-up question. Actually, we have one here from Barbara. This is a good one. Can you scuba dive with an ABI?
Yes, there's no problem with swimming or water sports with an ABI. Now, some patients with NF2 have problems with balance and especially buoyancy in the water. So I do not have a lot of my NF2 patients that I'm aware of that are swimming or scuba diving, but the ABI itself would not be a problem from participating in water sports.
All right, thank you. And this one is, Europe is using a MED, it looks like EL device versus Cochlear with possibly some better results. Is House considering doing a trial with the MED, either EI or EL device?
MED-L.
MED-L, okay.
Yeah, it's MED-EL. Yeah, the MED-L device is approved in Europe, and the Cochlear ABI device is approved in Europe and the United States. We have contacted the MED-L Corporation to bring the device into the United States, and at this time they have not wanted to go through the FDA process to bring the device into the United States. We've actually been in discussions with the MED-L group, and we believe that the reason there is better results between the two does not have to do with the device, but actually has to do with some surgical techniques that have been why we're getting better results recently.
All right, and then here's another question. Can you speak to what Coletti is doing in Europe and how House has learned from it?
So Dr. Coletti is a surgeon in Italy who started putting brainstem implants into patients who do not have NF2. He started doing this in children and now is also has some adults. I'm doing, for instance, an ABI tomorrow on an adult who cannot receive a cochlear implant, and we have already started discussions with the FDA. In fact, they have approved our ability to start a trial in putting the ABI into children.
Wonderful. Well, then there's just one more question from Barbara, and that's a follow-up on the scuba diving question. She wants to know about pressure with depth. Is there any complication with that?
Well, for every foot you go under scuba diving, you go up 3 times that if you were to go up in elevation. So There is quite a bit of pressure that occurs on the ear from scuba diving, but that again has nothing to do with the ABI.
And we did have another question that just came in. It says, how much does an ABI cost?
So an ABI and a cochlear implant are very costly. Both of the devices cost about $30,000 for the device. Fortunately, almost all insurance plans cover the cost of the device.
Okay. A couple more just rolling in now here. Here's one. They're asking if we can get your contact information out to everybody so they can ask some individual questions. Would that be possible, Dr. Slattery, that we put that out in an email?
Sure, that'd be fine. My email is drslattery@hei.org.
All right, thank you very much. And I think that's all the questions for this evening. Well, let's see, another one just came in. Oh, yep, this is another one. And do you mind one more question, Dr. Slattery?
Nope, that's fine.
All right, then we'll take this as our last one. Could you expand on the surgical techniques?
Was there something specific about the surgical techniques?
Okay, well, let's see another.
While they're addressing that, I can say there's 3 different surgical techniques that are usually used for the acoustic neuromas. The middle fossa approach, where we come from above for small tumors. The translabyrinthine approach, where we go directly through the inner ear for all size tumors. And the suboccipital or retrosigmoid approach, where we come from behind for small to medium-sized tumors when we want to try to preserve the hearing.
Well, thank you very much, Dr. Slattery. I think that really wraps up the questions that I see that we have here today. I want to thank you very much from the NF Network and from all of our participants for giving your time so generously to us this evening and for giving us a great presentation and answering all of our questions. Thank you very much, and thanks to everyone who participated tonight.
Well, thank you for having me. Let me just comment, Dr. Slattery is one word with no space and no period in my email address. So it's drslattery@hei.org.
There it is.
Perfect. Thank you.
All right. Thank you very much, everyone. Good night.
Okay. Good night.